This presentation focuses on the first aid and medical treatment. And here, the focus initially is recognizing the symptoms, responding with oxygen, communicating with whatever resources are available to assist in either stabilizing, treating, evacuating, or ultimately recompressing the individual. And finally, whatever options are there to increase the probability and reduce the time or delay until recompression treatment may be commenced. Obviously, maintaining life is the most significant priority, so airway breathing circulation is first. 100% oxygen is then provided, preferably either by a demand valve or a non-rebreather mask at 15 liters a minute, or if the person is not breathing, with either a pocket mask, bag valve mask, or even intubated via an endotracheal tube. The position is preferably with a person supine, legs raised if there is shock, and if they are breathing spontaneously on the left lateral side, to minimize the chances of breathing in stomach contents and to some extent to favor the elimination of bubbles from the heart to the lungs. Fluids, usually from a medical sense, this would be intravenous, and saline, ringers, or if the person is in complete control of their airway, they might be able to drink isotonic fluids. And in the first hour, one attempts to increase the volume of the body by about 1 to 2 liters. Obviously, if the person takes it orally, one needs to be careful that the person's consciousness is in place and that there's no risk to the airway or aspiration of stomach contents. After the initial bolus or pulse of fluid, one tries to maintain urine output to the extent of 2 milliliters per kilogram per hour. So a 100 kilogram person should eliminate approximately a cupful of urine every hour. The treatments that are actually recommended, in other words, based on science, in the treatment of decompression illness include surface oxygen, and here one would continue to at least 6 hours if recompression is to be commenced relatively soon, or as long as 16 hours continuously if recompression treatment will be delayed more than 24 hours. Hydration, which was just described, recompression to 18 meters, which is covered in another lecture, prevention of overheating, which aggravates neurological problems, avoidance of high glucose levels, which also aggravates neurological problems, and avoiding of deep venous thrombosis by using anticoagulants carefully under medical supervision in cases of paralysis and spinal cord decompression problems. Agents that might be helpful in selected cases and might be employed under the supervision of a diving physician could be a heart medicine called lidocaine or lignocaine, as well as anti-inflammatory drugs. What has not been proven to be of value is high doses of cortisone and complete anticoagulation. In the future, there may be other agents, including brain protective agents and nitrogen elimination, oxygen enhancing medications. In terms of reporting and recording the history, clearly the depth, time exposure, the decompression and stop schedule, repetitive or previous dives and problems, anything that happened during the dive that was untoward, and clearly whatever may have affected the dive buddy or other members of the dive group that would probably have been subject to the same type of exposure. The goal, if all things are equal, would be to get the diver to a recompression facility within less than 4 hours. Usually it's either denial by the diver of their symptoms or transport issues to get a diver to a chamber that results in delays longer than this. If a diver is to be flown in an aircraft, every effort is made to avoid decompression greater than 1,000 foot above whatever altitude the injury occurred. At sea level, one would then try to limit the altitude to 1,000 feet. This is typically important within the first 24 hours. If the person was diving at altitude, then the cabin altitude could increase to 1,000 foot above whatever that was. Lastly, it's important to monitor the buddy and, in the case of a diving fatality or serious accident, to impound the equipment, to turn off the pillar valve of the diving cylinder, and to leave it subject to further investigation. Recompression treatment is the ultimate treatment, and we've discussed the implications related to that. For the most part, though, the errors that are made in managing decompression illness is when the diagnosis is not made, when a pneumothorax is not identified, or when low blood glucose is not recognized as being the cause of the disruption of consciousness. When in doubt, recompress, and of course, we are still in a learning process, and therefore, perhaps cynically one might say, as a medical school professor once did, half of what we taught you is wrong. Unfortunately, we don't know which half. However, and perhaps more confidently, we can say that for the moment, this is the state-of-the-art information.